everybody. Thank you for being here. We're going to get started in just a minute. I appreciate you guys all joining. We are waiting on our two presenters who will be here very shortly. I want to thank you guys all for joining the SimiTree webinar on compliance and regulatory. Our presenters should be here in just a minute. There was some confusion with which link they had to log in to the presentation. So as we're getting started here, I just want to remind you that if you have questions, please feel free to put them into the Q&A. We are going to try and save time at the end for any questions that you have. And we have both Laurie and Deb that are going to be presenting. And so they're going to look at your questions and get to them as we can. So we're very excited to have you here. Very excited to be joined today by Laurie Newlun and Debra Grott. They are going to walk you guys through the fun and exciting topic of home health and hospice regulatory and compliance update. This information, there's a lot of content. So, you know, as we go through this, there's going to be some slides that are going to be more regulatory information that we're going to move through in a quicker pace. And then there's others that we're going to go into more detail, but please feel free to use the Q&A as we move along. And there is a handout that will be shared here shortly. So I will be putting that into the chat here very shortly for you as well. Deb, do we have you there? And do we have Laurie?
Here, my video is not working for some reason. I'm not sure why.
Oh, well, we can hear you, so we can't see you. The screen looks black, so I don't know if you have a cover over your
I do not. So weird.
Missy, can you see me?
I can't.
Yeah,
see
I can see you, Laurie. Wonder if I log out and log back in, Missy, just to.
You could try it, or you can check your camera settings with the little caret next to it and make sure that you have the right webcam turned on.
Yeah, it's there. Okay, I'm jumping off and jumping back on.
If there is a question, if you guys don't mind putting it in the Q&A, that'll be helpful for me, or you can use the chat as well. So like I said, the handout will be shared here very shortly. And we're going to give Deb just a minute to see if she can fix her technical issue. And then we will get started here. Oh, well, that's okay. We'll just listen to your lovely voice today, Deb. So, no worries, no worries. I'm going to go ahead and share my screen. I'm going to turn this over to Laurie and Deb to get us started. So with that, I'll hand it off to you guys.
Hi, good afternoon, everyone. I'm Laurie Newlun. I am a senior manager here with SimiTree in the Regulatory Compliance and Quality Group. I am a registered nurse with a master's degree in nursing, and I'm certified in healthcare compliance and privacy. And as a part of my presentation today, I will also be covering some HIPAA updates for you, and we appreciate you joining us today. I'm going to let Deb introduce herself.
Yeah, my name is Debra Grott, and I'm a registered nurse and certified in OASIS. I'm a senior manager here at SimiTree in the Compliance, Regulatory, and Quality department. And I'm going to be going over some home health updates. We've got a lot of content within our presentation today. So we're going to do some high level on some things and a little deeper dive in the other. But we wanted you to have as much information as we could give you.
So as we start this afternoon, this is just kind of an overview of the areas that we'll be discussing either in a little more depth or highlighting as a part of this presentation. As you all know, regulatory updates are coming fast and furious all the time. There were even some today on the hospice side, which is primarily where I'll be concentrating on HIPAA and hospice. but we will be talking about HIPAA and the high-tech rule and some projected anticipated changes to those, especially in relationships to substance abuse patients. We'll be looking at survey and COP updates, of course, the COVID-19 public health emergency and the extension of that and regulations related to that, billing and payment compliance on the home health and hospice side, some updates to both the home health and hospice final rule and quality reporting. So as we move along, we're going to start out and we'll just be talking about the fact that when you look at compliance, regulatory, and quality, they really intersect one with another. Missy, if you could move forward one slide. And when you see your overall corporate compliance program within your organization, which covers your survey readiness as well as your billing and those applicable regulatory policies, those also, if you're familiar with all them, know that they intersect with your QAPI process and your survey readiness. So they really all kind of blend in together and what the expectations are for organizations. And that's one of those things that just today I saw some updates on about program integrity for hospices. So we'll be mentioning that as well as a part of this. Next slide. So we're going to kind of put our information today into really three buckets. We're going to talk about kind of the spillover between HIPAA and what happens with the Office of Civil Rights and the OCR and the enforcement that we see there. And as you all know, there's kind of two pieces related to that, and that's privacy and security. So we'll briefly be mentioning those things. Primarily the changes that we see are related to privacy. We'll also be looking at conditions of participation, enforcement actions related to those and what the state survey process currently is and anticipated changes and expectations that some of those started in previous years and are continuing or just now rolling out. So we'll be discussing those as well. And then of course, home health and hospice payment, the regulatory requirements around that, what the Office of the Inspector General and the Department of Justice have been looking at, what our most common areas of deficiency are, and what those concentrations are when we try to look at services that are being provided. In that first bucket under HIPAA, next slide, please. The Health Insurance Portability and Accountability Act of 1996, we should all be so familiar with that, that we know what that HIPAA stands for, those initials. And that was really legislation that provided data privacy and security provisions for safeguarding patient information, being whether it's kept in your office, transmitted to other providers, or those who assist you in quality or maybe billing. Those were standards put into place that have expectations that we will all meet. Under those, healthcare providers must understand and be familiar with that. We are, by the Office of Civil Rights, held accountable to what the regulations are under Title II, or the Administration Simplification Act, and that requires that we implement and have secure processes in place, whether those are physical processes or electronic processes, to protect patient information or any identifiable information for patients that we are providing services for. And next slide. Under the HIPAA proposed changes, next slide. Under the HIPAA proposed changes that I'm going to talk about, these really started out in December of 2020. And you may think, oh, that's a long time ago. Why are we just now talking about that? Well, because things move a lot slower in the HIPAA world versus what we see in the final rule under home health and hospice. We'll get a final rule proposed, 1 year late in the fall, and then we see those things implemented either that same fall or early in the winter of the next year. But with the HIPAA requirements, they really opened these up for public comment back in 2020, and they had a lot of proposals that they were looking at as a part of that. We anticipate seeing that these proposals will become finalized probably in March of this year. And so I just want to make you familiar with those things, even though they're not fully in place at this point in time. They are areas that you need to be planning for, because they will take some changes in processes and implementation within your organization. So under these proposed changes, the HIPAA covered entities will be required to post estimated fees on their websites for private health information access. That's, in the past, we've seen that OCR has slowly come out and said, first that you could charge, then they limited what you could charge for, and now they really want to make sure that there's transparency associated with that. So they will have requirements, we anticipate, that state that as a part of your website and those things that you have to post there, that estimated fees and fee schedules for access or information will be a part of that. Also, we see that under HIPAA, they want to require to provide individuals estimates of those fees. And if the patient, does ask, gives you a thumb drive and wants those things put on it, you have to take into consideration how that reduces your cost. And so there will need to be some evaluation within organizations of what the actual cost is. And I would anticipate that we will have guidelines around what those costs can be. For pathways created for individuals to direct the sharing of PHI, so people will be able to individually talk about that. And we really are going to see a lot of those changes within the substance abuse and mental health directives area, because it has been much more tight. And what we see with the value-based purchasing and quality improvements is they want to increase sharing of information. And so we're going to see some new recommendations around pathways so that electronic health information can be shared, still maintaining privacy rights, but more openly. Healthcare providers and health plans will be required to respond to certain records requests from healthcare providers and health plans in cases when an individual directs those entities to do so under access. So we've had a lot of individual access items that have been required, and what we'll see is more of those rolled up into a general request for access. The requirements for HIPAA covered entities to obtain written confirmation that a notice of privacy practices was provided, that's been dropped. That was a proposal within the initial information, and we are happy to say that how we have it now, where it's many times listed in your consent as one of those items that you provide to them, it will not require a separate consent. Covered entities will be allowed to disclose PHI to avert threat to health or safety when harm is seriously and reasonably foreseeable. So as all of you are, I'm sure, aware, if you read the news, there have been many stories over the years of people who someone should have known or someone was aware of changes, especially when it came to mental health services or care that could have been shared and improved the care that was provided for that patient, or kept others from harm. And so we're seeing some amendments to those type items so that information can be more readily shared and available to others. Covered entities will be permitted to make certain uses as disclosures of PHI based on their good faith belief that is in the individual's best interest. That really rolls up into the same information that we just discussed about providing health information so that it's readily available to ensure safety and provide information to improve continuity of care and coordination of care as well. In addition to this, of the minimum necessary standards, exceptions for individual level care coordination and case management uses and disclosure, that also falls under what we're seeing with some of the new value-based purchasing and quality requirements that the federal government is really invested in improving that coordination process. And so being able to coordinate among multiple entities and those who are involved in care and making that where it's not a barrier to care is very important as a part of the requirements for the OCR as well. The definition of healthcare operations has been broadened to cover care coordination and case management. In the past, some of those people we've contracted with who provided outside case management and care coordination have required separate releases. And so we'll see some of those things rolled up together. The Armed Forces permission to use or disclose PHI to all uniformed services has been expanded, and a definition has been added for electronic health records, which is just a new clarification as a part of proposed changes. Next slide. So on the HIPAA detail, the proposed new HIPAA regulations announced in December of 2020 are as follows: allowing patients to inspect their PHI in person and take notes or photographs of their PHI. This is going to require entities to really think through that process and how they will be able to implement this in a timely manner for access to information as you can see in this second piece, there will be timelines associated with availability of records. As it says, it'll change the maximum time to provide access from 30 days to 15. And some states already do that, and some will make it even smaller timelines. So we have to think through how in our organization we're going to operationalize that and implement this change. Requests by individuals to transfer electronic PHI to a third party will be limited to information maintained in the electronic health record. People can ask for a lot of stuff, and it takes different amounts of time to gather that information. And so to meet this timeline, they're really talking about your electronic private health information that will be provided. So states when individuals should be provided ePHI at no cost. That information already has some information out there in the OCR requirements. For several years, they have talked about the cost of paper versus time and ink and those type things. So we'll just see some more clarification around this information. Covered entities will be required to inform individuals that they have the right to obtain or direct copies of their private health information to a third party when a summary of the private health information is offered instead of a copy. So that's pretty clear about what that's saying. And then a definition, as we said, will be added to what is an electronic health record. And that really coordinates with all the things we're seeing about what's going to be released, the timeline it's going to be released, and we'll need to think through operationalizing those pieces. Next slide. So next slide. Under HIPAA update details, as I said, employees will need to get further HIPAA training. Whenever there are HIPAA changes, we are always required to provide training and have evidence that that training was provided to our staff. So we'll want to talk about getting our training updated, implementing a plan to get that in place, and providing evidence. The Office for Civil Rights has been cracking down on violations of HIPAA rights of access. So we've seen, as we looked at the things that have been reported, lawsuits around people not being able to have access to their information timely. HIPAA changes will shorten that time frame, and as we said, for providing those records. Concerns related to the definitions of the electronic health record, which include billing records as well. That's typically electronic as well. Those in the past have kind of been two separate buckets of information. We're going to see all that information rolled up into one and considered an electronic health record. Billing records will need to be provided when an individual requests a copy of their record. The privacy rule change also prohibits unreasonable barriers to individuals exercising their right of access, such as unreasonable identity checks, which may be a cause of confusion as to what qualifies as reasonable. So we can expect that we'll see some clarification around that, but as we move forward, I'm sure that there'll be some challenges around that information that will need to be provided to show that this is a person who actually has and should have access to private information. A definition's been added for personal health application, an application used by an individual to access their health record. We all have some kind of a form that we utilize for a request to access. And so I think we're going to see some more guidance around what should be included in that and more standardized processes. Healthcare organizations will be required to inform individuals about the privacy and security risk of sending PHI to a third-party application, since it is not required by HIPAA. So if you're using an outside vendor, which your information moves through, or someone wants their information moved through, they have the right to request that. We will need to give them information related to their risk associated with that. And we all know that the risks associated with phishing and all those type things that occur when it comes to any kind of electronic data are just increasing every single day. Change to the language of the HIPAA privacy rule regarding the need to provide copies of ePHI in the format requested by the individual. People will be able to ask us to provide that information in the format that is best for them. And so if you don't have processes in place, this is a good time to start talking about how you're going to meet those requirements and meet the timeframes that are associated with those. And the new HIPAA regulations will allow patients to inspect their PHI in person and take notes and photographs, as we mentioned earlier. So Efforts, next slide. Efforts to implement the new HIPAA changes will need to be initiated promptly after the federal rule is published to ensure it's possible to be compliant with new HIPAA regulations in 2023. That's why I was saying you need to start thinking about those things now, because they really are a lot of changes for some organizations, and certainly by the effective dates that they're going to occur. In 2019, a notable HIPAA change related to HIPAA enforcement actions occurred, and the OCR issued a notice of enforcement discretion after interpreting the requirements of the HITECH Act regarding penalties for noncompliance. We are seeing more and more penalties around noncompliance related to either HIPAA security or privacy and the HITECH Act, and those penalties will continue to increase. Okay, next slide. So new HIPAA and Part 2 rulemaking, the CARES Act is passed to ensure that every American has access to their information, and we know that the public health emergency and the COVID-19 pandemic really tested all of us when it came to how to get access, how to provide access, and really how to conduct business when we had to do that electronically and from remote things, and how to address the economic fallout related to that. So individuals suffering from substance abuse disorder must also be eligible to get treatment, get their treatment needs met. And this became very difficult during the public health emergency. And that's why we saw some of the new things around telehealth and all the new implementation. But along with those new implementation of electronic mechanisms to receive care and provide information, we also saw new challenges. And the OCR is really looking at those challenges, especially related to those in behavioral health and substance abuse. And the CARE Act improved Part 2 regulations, which are those related to substance abuse, by expanding the ability of healthcare providers to share the records of individuals with substance abuse, but also tightening the requirements in the event of a breach or confidentiality. And so they want to be able to have care coordination and those involved to be able to get information when they need it, but there are going to be tight penalties around those in the case of a breach of confidentiality. So you want to make sure that your mechanisms really meet what the requirements are. Uses and disclosures must be limited to a minimum necessary information, and consent can be withdrawn in writing by the patient at any time. The CARES Act also allows substance abuse information to be shared with public health authorities if it is de-identified in accordance with HIPAA rules. We know that for routine care information, we have been able to have coordination and provide quality improvement information. I think this is a first step for those things specific to this group of individuals. Protections have been put in place for those substance abuse patients, which place limitations on the use of substance abuse records in criminal, civil, or administrative investigations or proceedings. And there are prohibitions or discrimination against patients suffering from substance abuse. 2 new patients' rights have been proposed to better align Part 2 with the privacy rules. And the first one is the right to an accounting of disclosures. That's always been in place for regular records. Now this is being expanded into those Part 2 rules, and they will be able to request restrictions on disclosures for treatment, payment, and healthcare operations as well, and a requirement to establish a process to receive complaints about Part 2 violations and prohibitions after taking adverse action, a prohibition against taking adverse action against anyone, patient who files a complaint. We know that's been in place related to general medical records for a very long time. We've seen that within the hospice and home health worlds, states and QICs and various organizations have been required to now have a formalized reporting mechanism. And that's just a step that we move into further compliance for them. And then disclosures will be required to be made to the Secretary of Health and Human Services for enforcement and the HIPAA HITECH Act. So if you have violations, if you've had breaches, if you've had penalties, we will have that normal reporting mechanism in place. The same breach notification requirements as HIPAA will apply to breaches of Part 2. So any data breach will require the patient to be notified without unnecessary delay. This is just an expansion of what we've already seen with routine medical records. So it's just really putting this into writing and making it part of the rulemaking. And then the Part 2 confidentiality notice requirements will align with HIPAA notices of privacy practices. So now we're going to move into the conditions of participation, and Deb's going to take us through that.
Yes. So with our conditions of participation, as we know, these are regulations set forth that have requirements that the providers must meet for Medicare certified in order to receive Medicare or Medicaid payments. The focus is really on that patient care and coordination and management of that care and the quality around that care, patients' rights, and infection control as well. And the focus of the state surveyor and the agencies for accreditation, so CHAP, JACO, their organizations really is patient focused, not payment centered. So we really have to think about the separation between what is survey readiness versus what is payment compliance. Next slide, Missy. So for the conditions of participation, we've given you some guidance here on where you can find those COPs for home health and hospice. And you can also find the differences between the regulation versus the interpretive guidelines. The interpretive guidelines are great because they really tell you what your surveyors are going to focus on related to those regulations. So it's important to really look at those interpretive guidelines as well. Next slide, let's see, and conditions of participation. We're going to do some updates. Some of these updates we are familiar with already because of the COVID-19 waivers. Some of these things were taken into a final rule and made a permanent part of what we do. So the first big thing was that OTs can conduct the initial and comprehensive assessment for all Medicare beneficiaries under the home health benefit. Now, I will say there are some caveats around that. It's not just an overall they can do it. If nursing is on that referral, then your OTs or your nurses have to do that start of care. They can't stand alone initially, and they cannot decide if that patient meets the requirements for eligibility under Medicare or home health. So they can't stand alone. They have to have either PT or speech therapy to go in there to qualify that patient, that patient meets the Medicare home health requirements, and that they have that need for skilled nursing, physical therapy, and speech pathology services. And then at that point, once we establish that, therapy has seen them from physical therapy, speech therapy, and we want to reinsert that patient, or PT is going to pull out, OT can then continue once that ceases, but they cannot be the ones to establish and determine whether that patient meets Medicare eligibility. Next slide. Also, the home health supervision, home health aid supervision. So every 14 days remains for skilled care to ensure that the aid is furnishing safe and effective care. The visits can be conducted virtually via interactive telecommunication systems. In rare circumstances, then an on-site visit cannot be coordinated within that 14-day time period. That would meet the criteria. Limiting this virtual nurse aid supervisory visit to 1 per patient per 60-day episode, and only in that rare circumstance for an unplanned occurrence, then an on-site visit cannot be coordinated. So you must document the reason why you did it virtually versus why you couldn't go in person. But it does give us a little bit more bandwidth with our patients and really has helped. For those non-skilled patients, they're finalizing the supervisory visit requirements for non-skilled patients with modifications. So they're modifying the semi-annual on-site visit to require that the visit be conducted on each patient the aid is providing services to, rather than a patient that aid is providing services to. So we're going to go from a patient to each patient that aid is providing services to. Home health aid supervision. So additionally related to this, the competencies may reflect deficient practices in areas that should be addressed. Every circumstance is unique, and the supervising nurse has clinical judgment for this. So Deficiencies in care verified by the RN, she's the one making, or he's the one making that determination and determining, that what needs to be done in that next step for the competencies for that home health aide. That's the reason we put those supervisions in place, to make sure that the care that we're providing to our patients meets the criteria. We don't do anything outside the scope of practice that our home health aides are supposed to do. Our patients are satisfied. So all of those pieces are very important with the home health supervision piece. Next slide. Survey and regulatory challenges with the COVID-19 PHE. Remember, as of January 11, 2023, the public health emergency was extended. So, that's a great thing. I think it was extended for another 90 days. And if the trend keeps going, the PHE may get extended again. So survey and regulatory challenges in 2020 and 2021 were related to that COVID-19 PHE. And this is now continued into 2022, and again is going to continue right into 2023. The surveyors are really focusing on that infection control, surveillance, emergency and pandemic planning, the evidence that the organization is following the COVID-19 response, the compliance with the 1135 waivers, if your agency is utilizing the waivers. They're really prioritizing surveys due to the COVID backlog. So if your survey was pushed off due to the COVID backlog, they are rapidly catching up. So you can expect that they're going to be coming if you are past due. Evidence of compliance with the federal COVID-19 vaccine mandates, and sometimes that's unique. Federal has policies, but also states have policies. So you've got to kind of look at all of those pieces. And the COVID-19 PHE waivers, the waivers are still in effect, but will phase out when the federal PHE ends. So now we've seen it extended. Those waivers are going to keep going. But again, you really have to pay attention to your state-specific COVID waivers as well. I know here in Florida, we have some pretty unique state-specific things in place that we're always having a struggle a little bit with federal and the state guidelines. Auditors need to understand how an agency implements their waivers, if applicable, as well. So you really have to have that documentation to show how you're using your COVID waivers if you're using them, and it has to be clear to your surveyors and your auditors when they're there. Next slide. Accreditation and state surveyors. The home health agency must maintain and document an infection control program, which has its goal, the prevention and control of infections and communicable diseases. I feel infection control seems to be the thing that we've constantly need to be aware of on a survey, because our surveyors, when they're going with our to see our patients, they're choosing those high infection control patients, wound cares, things like that. Standard is the prevention that you as a home health agency must follow accepted standards of practice, including the use of standard precautions to prevent the transmission of infections and communicable diseases. And then the control aspect of it, that you must maintain a coordinated agency-wide program for the surveillance and identification of prevention, control, and investigation of infectious and communicable diseases. And that's an integral part of your home health agency's CHQRP program. The infection control must include a method for identifying infectious and communicable diseases and the plan for the appropriate actions that are expected to result in that. So, I think standard 101 on everybody's CHQRP plan, we're always doing some type of infection control methodology to work with. And, because again, with COVID, the waivers moving forward, infection control, hand washing, the following of your policies is a big piece for your state surveyors. Next slide. Standard education that the home health agency must provide infection control education to the staff, patients, and caregivers. COVID-19 vaccination of home health agency staff. Again, a hot topic. Home health agency staff must develop and implement policies and procedures to ensure that all staff are fully vaccinated. And for the purposes of this section, staff are considered fully vaccinated if it has been 2 weeks or more since they've completed a primary vaccination series for COVID-19. The completion of a primary vaccination series for COVID-19 is defined here as the administration of a single dose vaccine or the administration of all required doses of a multi-dose vaccine. So it's very important that you, again, look at your state guidance and your federal guidance related to the vaccine, and you have policies that support what you're doing and have policies to indicate that if you have staff that are not eligible, or they meet that exemption for the COVID-19 vaccine, that you have all the policies to back that up in the documentation in your employees' records to ensure that you'll meet that standard when your state surveyors are there. Next slide. The top 10 survey deficiencies. Now, remember, this is for 2021, 2022, because we obviously don't have, that's how they put out their data 1 year prior. I feel that these really haven't changed a whole lot. They continue to be the same top 10 survey deficiencies. Standard content of your plan of care, which is really a broad way of saying, that there's something wrong within your plan of care, whether it is, the way that you don't have short-term, long-term goals, things like that. You're not putting frequencies on there for all of your disciplines that are seeing. All of your disciplines are not contained if they were done in the 5-day window, things like that. There's a whole myriad of things that can be contained in that deficiency for content of your plan of care. Content of the comprehensive, content of the comprehensive assessment, especially around medications. Medications seem to not be updated as they should be, and that is updated in the record, in the home, and that the patients, everything is up to date in the patient's record. Again, another one for standard plan of care, infection prevention, infection control. We just kind of talked a little bit about those. Big one, discharge and transfer summaries, that you're not sending those off to the physicians or the receiving entities that are receiving your patients with your transfers. They have to be done in a timely manner to meet that standard, and they have to have some kind of documentation or evidence that it was done. In respect to skilled professionals, that the provided services are ordered in the plan of care. Again, another part to that plan of care, and only ordered by the physician. Again, we know that physician means nurse practitioner or PA, the person that is eligible to provide you orders in your agency, depending upon your state standard, but you can only take orders from those particular patients. You have to conform and plan and do your care to your patient based around those physician's orders. You cannot, go out and provide care to a wound or something without physician's orders that were not provided to you by that physician. So it's always following those physician's orders. And then promptly alerting the physician to any relevant changes to your patient. So your patient has had some kind of change. You need to make sure that the care coordination is there with your physicians. Bucket 3 is compliance with billing and payment. I will tell you, this is a hot topic right now because we are seeing a lot of government agency audits related to some of billing practices and payments. So we've put in here Medicare, hospice, and home health benefit manuals so that you can reference those. Also the program integrity manual and other related websites that you really need to check for updated guidance. They're all here for you in one slide. Next slide. And the key issues in home health and hospice. So right now I can tell you, I handle all the government audits in our compliance department for the home health side, and we are seeing the myriad of them. I can tell you TPE is rampant right now. ADRs, which are used to be a straight up ADR, are now almost called a RAC, that recovery audit contractor. We are seeing SMRCs, we are seeing certs, we are seeing UPICs. We are working with the OIG and working on, work plans for agencies who have gone that far through some government audit processes. So I can tell you since, COVID, we've allowed, the government has picked up all of their practices again. We are seeing them come out of the woodwork. So if you're on this call and you are not affected by one of these things in either the home health or the hospice realm, I can tell you you're lucky, because most, we're seeing a ton of it right now. So why are home health and hospice providers being targeted? It's, really, it's to continue to increase, to make sure that the beneficiaries are receiving the care that they deserve, and that we are being appropriately paid and appropriately billing Medicare for the services that we're providing. They're monitoring the spending outside of the Medicare hospice benefit. They are looking at overpayments, fraud, and abuse practices, and they are real. They are looking at all of your data, your PEPR, your claims data, your quality data, your max looking. I mean, everybody's looking to ensure that what you are doing meets that criteria of what your peers are doing. Because if you have something that stands out on one of those reports, they're going to come looking to see why you're standing out above what your peers are. We have got many government initiatives. Some are focused, some are more broad, some are looking at potential just, 8 or 10 codes. Some are looking more at, an overall view of your billing practices. So you can really get something for a wide range of reasons, to be able to prevent that widespread potential for actual fraud and abuse, for sure. Next slide. Areas of focus for home health. Low-hanging fruit right now is your skilled need medical necessity. That's looking at all disciplines. Face-to-face encounters are a big piece right now. Long lengths of stay and short lengths of stay. They are really looking at catheter patients and ensuring that if this patient has had this catheter for a while, you truly are following the guidance of Medicare and looking at this patient, going and seeing this patient once, every 30 days, unless there's a PRN visit. And if you're doing more than that, they're kind of looking at why you're doing more than that. If you're providing a patient with care and you're just over that LUPA threshold, they want to really know, did that extra visit you did, does it meet medical necessity, and does it have a skilled need? And if it's not, they're really taking them back. They're telling you, give me my money back. Technical is a big thing. They're looking to make sure that your signatures, dates on the 485s are legible. And that they are dated prior to you dropping that claim. That's a big thing. Therapy utilization, 30-day therapy reassessments are a big piece, making sure that you have objective measures, comparative data, that you provided a skill on that visit, and that you are not having duplication of services between your PT, OT, and speech. Everybody's not in there doing the same thing. If you're in there and your PTs and your OTs are teaching the same things, working on the same things, they're only going to pay one service. They're not going to pay for both. ICD-10 coding and your OASIS coding and documentation is very important. They're checking to see if you're upcoding with your clients and that your face-to-face encounter is truly for the reasons that you're seeing that patient in home care, and that your coding kind of matches all of that. Care plan implementation, PDGM comorbidities and your admission source. So, making sure that if it's a facility or a community admission, they're looking at those. COVID-19 telehealth visits. Are you using audio and video? Referral relationships and incentive programs. And then of course your PEPR reports. So it's a big thing in home health that we're really looking at a myriad of reasons why you're getting and receiving these government audits. Next slide. Home health denial reasons. We talked a lot about this. I would say that medical necessity skilled need is number one, followed up by homebound status. Our EMR systems are not doing us any favors where we've got point and click information, and we are having to, when we look at a chart, we want to make sure that the information contained in that chart is specific to that patient. If your clinicians are using all point and click documentation, there's nothing unique about that documentation that pertains to your particular patient. So please make sure that your clinicians are writing some kind of a little narrative about your patient to make it patient specific. 30-day RFAs, again, we talked about that, technical signatures, and then the face-to-face encounter are those high denial reasons. Next slide.
So for denials under hospice, I will just say that many of these things overlap what you've heard Deb say for home health. You do want to take note of these items. Many have not changed from previous years. They are looking at the data that's provided. We just today saw information come out from long-term care facilities regarding increased scrutiny around infection control. So we can expect that as we overlap in the hospice world with those long-term care facilities, we will also be subject to many of these things. And this is really just a list that most of you would be familiar with those items. The next slide really outlines hospice denial reasons. Once again, these are common reasons that we have seen throughout the years. There's not much change to that. So I would just say that be familiar with this, make sure your records are meeting scrutiny from the point of election all the way through for all services provided. Next slide.
So for home health 2023 final rule changes, we're going to just do a really quick high level overview. A lot of it has to do with payment changes. And as you can see in here that initially there was a significant rate cut intention for 2023, but instead they kind of did an aggregate payment, and it equated to a smaller amount of rate cut for us. But that doesn't mean that that rate cut's going to go away. It just kind of means that this year they've only used a small portion of it, but that doesn't mean in 2024 that the intentions won't be to make it a little bit deeper. I will say that MedPAC has come out this week with some information related to possible integration and recommendations for 2024. If you've seen that, remember that that's just recommendations. A lot of times with the MedPAC comes, they reach for the stars and they don't technically get everything that they want when it becomes, down to the final rule. So if you've seen some of that MedPAC information come out, just, be aware that that will change. We've had some base rate changes, just some minor changes from 2022 to 2023. We've had some behavioral adjustments phased in with an estimated 3.9 decrease in 2023. That's kind of just that phased in approach. And, a lot of that behavioral adjustment, we have finally righted ourselves as we've gone in home health. Some of it we've caused ourselves over the years, but we're finally, starting to, the government has finally worked their mindset on us and kind of changed the things that that we're doing within our practices. Recalibration of case mix components has been a big thing, including classification reassignment to certain diagnosis codes and functional impairment levels. Next slide. You can see on here, the LUPA thresholds have changed, and I've just kind of given you the overview number of that. Some have increased by 1 visit, some decreased by as much as 3 visits, but it only affects certain HHRGs, so you really have to be cognizant of those HHRGs. And CMS has decided that they are going to make the OASIS data set for all payers beginning in calendar year 2025. They have been discussing this for a while, and currently we only do it for, it's only required for that skilled Medicare, Medicaid, but they are going to phase in from January 2025 through June 30th, 2025, where it, will be a phased in approach and voluntary until it becomes into a total effect. And then in 2027, if you are not doing it completely, then you could get imposed some penalties, for those non-Medicare, Medicaid payers. HCPCS codes have also been added to capture telecommute telecommunication services. And in the next slide, we've kind of overviewed that a little bit. Voluntary claim reporting beginning 1/1/23 through 7/1/23. There's 3 new G codes that kind of go along with that. And services are not going to count towards your LUPA threshold or reimbursement, but we are able to at least take credit for the telecommunication things that we're doing with our patients. And there's going to be further program instructions to be issued. I think COVID-19 was a big push on this, and it's allowed us to kind of get some legislation around some of it. So I think there'll be a lot more to come on a little bit more about that telecommunication. Next slide. Case mix changes. Again, I've put in here just a high overview of the changes in some of the HHRGs, where it's changes ranging from -5% on up to +5%. So you can kind of take a look at the final rule and the pieces of those HHRGs, so you can kind of see a little bit more deeper dive on what those changes are. Next slide. Next slide. There we go. Regulatory updates, face-to-face, and the CARES Act language. So they revised that statutory language to permit the certifying practitioner to document that any allowed practitioner has conducted the face-to-face encounter, regardless of whether they're the certifying practitioner or collaborating with the certifying practitioner. So some of these changes have gone on: plans of care and certifying and recertifying of patient eligibility. So it allows Medicare eligible home health patients to be under the care of a nurse practitioner, clinical nurse specialist, or PA. But remember, that's in working with your state law. There are still many states out there that do not allow that the PA, the clinical nurse specialist, the NP to provide orders to home care and to sign off on those plans of care. So you really need to know what is involved in your state practice act to understand it, whether you can accept orders from these. The physicians and practitioners can order home health services, establish and periodically review a plan of care, and certify and recertify that patient is eligible for the Medicare home health services. These changes were effective March 1st, 2020, but they provide the flexibility needed for more timely initiation of services in the home health patients. So I think COVID was another big push in this. It allowed us, to get some more bandwidth with some of the things that really needed to change in our legislation. So it's a great thing. But again, making sure that you're looking at your state regulation. Next slide. The definition of allowed practitioners. So it's allowed practitioners, in addition to physicians, can certify and recertify beneficiaries for the eligibility or to order home health, and establish and review the plan of care. So these are defined by the 484.2 as physician's assistants or PAs, nurse practitioners, NPs, or your clinical nurse specialists, the CNS, as defined by this part. They are required to practice in accordance with their state law, as we discussed. So you really need to kind of watch what your state laws say, because some say they can only be a collaborating part with a physician. They can't be the one to order and sign. So you really have to take into account what that says. April 27, 2022, the CMS reissued the change request to remove the changes in Chapter 7, Section 30.2.1, titled The Definition of an Allowed Practitioner. So they have gone through and made those changes. But again, you really have to scope out your practice act within your state. Next slide. The NOA, we've been dealing with this since January. So home health agencies, it's something that was new to us, but we're getting used to this. And home health agencies must submit a one-time NOA that establishes the home health period of care and covers all contiguous 30-day periods of care until the individual is discharged from Medicare home health services. The NOA is something that hospice has been used to, but we just really haven't been used to it in home health. You have to submit that NOA to their MAC within 5 calendar days from the start of care. And that NOA is a one-time submission that establishes that home health plan of care and covers contiguous 30-day plans of care until your discharge of the individual from the Medicare home health services. In instances, though, where you don't file that NOA timely, Medicare can reduce your payments for that payment period, including outlier payments by the number of days from the home health admission date until the date the NOA has been submitted and accepted by the MAC. So in order to figure that out, there's like this formula that you can divide it out by 30, and you take that number and you subtract it for every day that you're late. And that should give you a close to what your NOA payment or what your payment would be for your late NOA. No LUPA per visit payment shall be made for visits that occur on days that fall within the period of care prior to the submission of NOA. So this reduction shall be a provider liability, and the provider shall not bill the beneficiary for it. So that takes into account those LUPA patients. So you really have to be careful and make sure those NOAs are submitted timely. CMS may waive the consequences of failure to submit if it's determined that there was a circumstance encountered by home health agencies that's exceptional and qualifies for a waiver of circumstance. You know, for example, here in Florida, we had the hurricane. They did waive some stuff for that. You know, so there are some circumstances that they will. Next slide. Home health QRP, this is our quality reporting. I'm kind of just do a high level because I know we're running short on time. It talks about what was currently adopted in the quality measures, and you can see it. We put the NQF with each one here so that you can see that. I know there were some questions in the Q&A about quality measures. If you want to shoot me an email, I can certainly get you the answers that you were looking for on that. Next slide. The measures and the data, again, it talks about timeliness of care, the transfer of health information, provider for post-acute and patient to post-acute. Again, this kind of does a quick overview of the things that are changing and adopted in calendar year of 2022. Next slide. Changes beginning in 2023, which were removing that drug education on all medications because we did change our behavior on that and we did well. So they decided to remove that measure. They removed it from the home health star ratings in 2019 and replaced it with the improvement of management of oral meds. And that data will continue to be reported on Care Compare through October 1 of 2023, and then it'll be removed from the site. Next slide. Beginning in 2023, the acute care hospitalization during first 60 days and emergency department use will be taken out and added that home health within stay potentially preventing hospitalization measure, and assesses the agency level risk adjusted rate of potential preventable inpatient hospitalizations. So these are going to be kind of put in, they're claims-based measures. So no additional data collection or submission burden for the agencies, but they're going to kind of just like take a few out and add a few in to just take the place of those without burden to us, which is a great thing. Next slide. For Oasis E, you know, we're living the dream right now, and VBP, there was a lot of changes with the VBP. I will tell you that for SimiTree, we have a lot of webinars related to Oasis E and VBP, and I would suggest you jump on those. If you haven't, sign up. Listen to our experts on both of them because they have a lot of great information out there. So jump on those Oasis E and VBP webinars and learn the deep dive into both of those. Next slide.
So for hospice information, I would also recommend that you look at previous webinars and webinars we have upcoming, as we will be and have covered a lot of these changes. As you all know, for hospice, there weren't a lot of changes this year, and it's outlined here what our payment increase was. I will say once again that MedPAC had much deeper cuts and things in mind, and they did not receive that. So be familiar with MedPAC, but don't always take that those things will be completed in the end. One of the major things is that decrease in reimbursement related to 2% for quality measures. That's a big thing we all need to be we need to be aware of. The HOPE tool, which is sort of an OASIS type product or a standard assessment product for nursing, which will include a multidisciplinary group for nursing, social work, and spiritual. They will be required. That's in the national beta testing phase now. And so just be aware that those are in place and they are coming very quickly. Next slide. For the timeliness for program integrity provisions for hospice here, many of these were already implemented over the last 2 years. I just left this here because I wanted you to know that it's still phasing in with all the requirements. They aren't quite complete yet. For the next slide, we want to be sure and note that there have been some more stringent requirements around survey processes for hospices. As we know, increased education for surveyors, more transparency around reporting deficiencies, that regardless of who does your survey, whether you're done by the state, federal accreditation survey, those type things, that there will be more clarity and transparency to the public. So as a part of the changes that happened, what we saw last year and are still being implemented, next slide, are the enforcement remedies. And this just outlines the enforcement remedies. There are very specific ones that we're going to start seeing. Those haven't been fully implemented yet, but we are beginning to see those things phased in related to survey findings. Next slide. For fiscal year 2023, rate updates, in the final rule, as I already talked about, we had a 3.8% increase. That is across all of your payment levels. So, CBSA codes and where you're located affect what your payment is. So you want to be familiar with what your payment is. The hospice cap had an increase related to this 3.8% increase. And of course, that 2% reduction took place if you had not reported quality information appropriately. The next slide outlines updates for future quality measures. There were no new quality measures implemented for this year. However, there were many proposed measures that are being reviewed. So just know that while the quality information, and we'll see a continued phase in up to 4%, there will be changes to those quality measures as we move along. And you should be familiar what the proposed measures are. And that's on the next slide. When you look at that, you can see information related to the quality measures for 2022, 2023. And then also be aware on the next slide, we talk about the hospice care index. Now the hospice care index is a little bit different in that it takes multiple indicators and rolls them up into one quality measure. So it breaks down some of those single items that we may have measured in the past, moves those up into one measure that really kind of gives an overall view of that index scoring and will affect the quality information. For the next slide, this is just a breakdown of kind of what rolls up into those quality measures. So if you're not familiar with that, utilize this score. Also understand top box scoring, because that will play into the quality measures, how you compare to others in your peer group. And the next slide also outlines that additional information. On the next slide about the HOPE instrument, we've got some more detail about HOPE and then what the expectations are that. We talked about the fact that it's in national beta testing now, so we can anticipate within the next year, we'll start seeing and hearing more about those standardized data collection elements that we will have applicable to hospice. On the next slide, we have more information related to that HOPE measure. If you're not familiar with that, take the time to read it. There's lots of information available on the HOPE measure. For the next slide, we talk about telehealth visits. As Deb mentioned, the public health emergency was extended, and we know as a part of that, the ability to do use telehealth to do recertification visits has been extended as well. We know that there are also measures in place for permanency of some of these items that were related to the public health emergency to make things more available for folks, and in some cases reduce infection rates related to those as well. So this is a part of the Consolidated Appropriations Act of 2022, which is the COVID rule, really is what we call it. And that flexibility has been extended beyond for another 151 days. The next slide talks about the hospice cap survey. You should be familiar with the fact that we are looking at changes to the hospice cap survey related to the way that it's implemented. and use of electronic mechanisms to be able to collect data on a web-based mode. They have put in place a expert panel to look at these measures and the processes in place. And that's another change that we can expect to hear more about and see within the next coming year. This information is really going to be volume based. And so we may see some modifications to the way that information is utilized as a part of our quality measures as well. And if you're not familiar with hospice star ratings, we kind of talk about that on the next slide. Those have been implemented. We had a dry run from November of 21 to March of 2022. It has been implemented. We know that this is going to be part of our payment reimbursement process. And so be sure that you are familiar with the star ratings process. And then the next slide just kind of gives you a breakout of how they're reported, especially since we had a break in reporting due to the public health emergency. I would like to thank you all for the opportunity to provide this information to you today. I'm sorry that we ran just a little bit long. I hope that you find it helpful. If you have any questions, please feel free to submit those, and we will be happy to respond via email.
And
Thanks,
for
Mitzi.
those that sent some questions here, I've got your names and we're going to circle back around with you and shoot you an email with these answers.
Absolutely.
So thank you all for joining the webinar. It was great to have you here. You will receive the recording and a copy of the handout in your email in the next 48 to 72 hours. As always, we welcome you to any SimiTree webinars and hope to see you again in the future. Thanks, Deb and Laurie. Great job.
Thank you.
Thank you.